grateful to see all of you who've got up early to listen to this morning. I apologise, I've got two talks back to back this morning on possibly the less interesting side of aortic dissection. I think aortic dissection is one of the frontiers we've yet to conquer, and so it's the thing that really interests me. I think aortic dissection is difficult to describe if you're talking about classification. The aorta we know dissects spirally and randomly, and therefore pretty much every patient you see has a personalised dissection. They're tricky to report and they're difficult to compare treatment modules because of the differences in the dissection. There have been a variety of descriptive modalities, so anatomical, time since initial event, whether they're complicated or uncomplicated. And traditionally, I think most of us in the room have grown up with using the 𝗷𝗡𝗊𝗃 or the Stanford classifications, and they are anatomically defined by the site of the 𝗟𝘃𝗃 and the extent of the intimal flap in the 𝗷𝗡𝗃 classification. The Stanford is by far and away the simplest and probably the most commonly used. If I think back over every conversation I've had with a registrar over the last 20 years, they would normally start with, there's an acute type B aortic dissection. And so I think it's the terminology we use the most frequently. But the problem is it doesn't really account for the non-A, non-B dissections, so where the 𝗟𝘃𝗃 is in the arch, of which seem to see quite frequently. It doesn't tell you whether they originate or extend into the great vessels of the neck. It doesn't describe retrograde aortic dissection, and it certainly doesn't describe those other conditions that are linked to dissection, so intramural hematoma or penetrating ulcers. We talk a lot about timing, and this is the more old-fashioned timing classification, so acute less than 14 days, chronic greater than 14 days, and there wasn't really ever a subacute group. And that acute and chronic classification was purely based on the very early observational studies that showed that people stopped dying after 14 days. So the assumption was that the dissection flap had matured and had become less dangerous. Uncomplicated versus uncomplicated, I don't need to tell you about this. Essentially, anybody with a rupture, end organ ischemia or persistent pain is complicated, and everybody else is deemed uncomplicated. The problem with all of these things that I've just talked about is that in all the literature, you end up comparing apples with oranges, I think, because you have the treatment options, which are medical treatment alone, small amount of open surgery for type B aortic dissection, but endovascular repair, which is becoming increasingly more complicated with potentially more options, but we don't really know how to evaluate them because we can't compare them and we don't know whether we're comparing them similar with similar. So, very luckily, the SVS and the STS in the United States, led by Joseph Lombardi, but a collaboration of many vascular surgeons across the States, looked at the classification of dissection to see if they could make it better. And I think they have, actually. So type A dissection, they define it as a tear in zone 0, and the distal extent by where it goes. So a type A9 would be down to the infrarenal aorta. Type B, entry tear, the first number is where it starts, and then the second number is where it finishes. So type B 311 would describe a dissection. You can describe a retrograde dissection because you can start with your most proximal extent being 0. You can also describe penetrating ulcers and intramural hematomas in exactly the same way by designating where the hematoma is on the zones and where the penetrating ulcer is on the zones. They've also changed the timing classification, so they've added a hyperacute and a subacute phase between 15 and 90 days, and I think they're very useful distinctions because the aorta is more fragile in the first 14 days, and we know that from the registry data that we've got that there is still an ability for the aorta to remodel out to 90 days, so I think they're all important things. They've also described a high-risk category. So we talk about in our MDTs all the time, so this is an uncomplicated patient, but are they likely to be a rapid expander? Do they have any of the risk factors which we've come to realise are things that are important. So do they have... And so, in summary, day-to-day clinical conversations, I think, are likely to carry on with the Stanford or the 𝗔𝗶𝗃𝗃 classifications and whether they're complicated or uncomplicated. But for the purposes of publication, comparing treatment modalities, registry data, I think that the SVS classification is a vast improvement on the old descriptors, and I would encourage everyone to adopt it, that all your authors and researchers in the audience, to ensure that we're comparing like with like and can make sensible decisions about which treatment modalities are useful. Thank you.